So I'm talking about transcutaneous retrobulbar amphotericin B. Uh, so I'll quickly go to the main slide that is of interest. I think given that imaging and exenteration and debridement have been covered, it is important to us for us to know what uh, route of treatment is indicated in what cases. And I think we can all agree that radiology, especially the loss of contrast enhancement on MRI, cavernous apex involvement, and the cavernous sinus status are important factors that help us figure out whether we need to exenterate or whether we can go ahead with any other indication of treatment. So these are, now say for example, this on the left of the orbit, you can see here that none of the muscles are taking up any contrast in contrast to the other side. So this is a completely infarcted orbit where there is complete loss of contrast enhancement. Here you can see that there is this medial rectus has a sliver of contrast being taken up. So this essentially is a dying muscle. And when we exenterated, you could see that nearly 3/4 of all of that, including the medial rectus here, was had completely necrosed. So this, I think, is the most important slide that I'll just be on for 5 minutes before we wrap up. Are basically the radiological features that we see. It's a busy slide, but I'll go over it, try to cover it entirely. These are the radiological features that we see on MRI that help us decide whether we need to exenterate or whether we need to give retrobulbar amphotericin B. So the first thing that we see is subtle enhancement that is adjacent to a sinus. Now here you can see the maxillary sinus's involvement, the extraocular muscle is the inferior rectus is enlarged and contrast enhancement is seen. In this case, you would want to give retrobulbar amphotericin B. The next would be in cases where you see clear contrast enhancement with an increase in size of the muscle adjacent to the sinus. So again here there is very minimal orbital disease. There is contrast enhancement and increase in size of the muscle. The frontal sinus here is more involved, so therefore you can go in and give orbital retrobulbar amphotericin B here. The next thing would be where you see perineuritis, and again the extraocular muscles are showing uptake of contrast. So there is diffuse orbital inflammation, perineuritis, but there is apical involvement seen here as well, where you would want to go ahead and give retrobulbar amphotericin B. Now here again, this is another case where you see contrast enhancement of the apex where the cavernous sinus is not involved, so then this again is an indication for retrobulbar amphotericin B. This is loss of contrast enhancement at the apex. Now here you can see, again this would be an indication for you to go ahead and give retrobulbar amphotericin B. Here you can see complete distorted globe where none of the muscles are showing any contrast enhancement. In this case, you would not go ahead with retrobulbar amphotericin B. It's important to know that the clinical presentation, which is ptosis, frozen globe, chemosis, proptosis, are similar across in the entire spectrum. So clinically alone, to be able to say whether this is stage 3A, 3B, 4A, 4B as per all the unvalidated classification systems is very difficult for you to decide which patient needs to be exenterated or which patient needs to get retrobulbar amphotericin B. In this case, with gross distortion of the globe, optic nerve stretch and complete loss of contrast enhancement of the extraocular muscles, it is a candidate for exenteration. Now this would be a patient where you can see limited orbital disease. This is one of the patients that Raghuraj was mentioning. Is a sequelae where post-aggressive initial treatment, the patient is on posaconazole, but about 3 months later comes back and you still see some residual disease in the orbit. Here the patient is more amenable for an orbital debridement. And finally here the guitar pluck sign, again there is complete distortion of architecture of structures in the orbit. This is a case for a clear orbital exenteration. So again this is perineuritis with no appreciable orbital structures involved. Now if you see even in the coronal structure slice, you can't even identify the extraocular muscles over here. That is completely necrosed, and therefore this and we are surprised to see contrast being taken up in the optic nerve sheath, because you would have expected that also not to show up given the necrosis happening there. Again, this is globe distortion with intraconal abscess, which perineuritis with intraconal abscess, where orbital exentration is indicated. So what is the evidence? It comes basically from case reports that initially started to treat mucormycosis. Finally, we had a case in early 2020 where COVID-related mucormycosis was treated with atrobulbar amphotericin B. And also there's a lot of evidence in aspergillosis where this was used, and using that evidence, we used it in mucormycosis. This was a case of a patient who was actually not COVID-related, mucormycosis, who had previously undergone an ENT surgery for mucormycosis. Right eye was no PL, left eye 624, presented with both eyes frozen globe. This was the imaging. You could see that patient has, CT scan was really not very helpful. So we did an MRI. You could see both sides showed enlargement of extraocular muscles and disease present in the residual sinus structures as well as the orbits. So patient again was debrided. There was systemic amphotericin B given, and tram was given in both eyes with the hopes of saving the orbit. Here you can see contrast uptake is there. So this is 3.5 mg per ml being diluted, and then after antecedent local anesthesia, you inject into the quadrant which is involved. You can also spread it over 2 or 3 sites based on the amount of inflammation that you see on MRI. The patient underwent 3 injections on alternate days, and at the end, the patient could recover completely from the frozen globe and ptosis that the patient had, and the 624 vision remained. So it's important to monitor these patients. You have to remember the dilution and the site of injection based on MRI. So to summarize, I think imaging and clinical information will guide which patient needs which mode of treatment. TRAMB alone is not the be-all and end-all. TRAMB goes hand in hand with systemic therapy, systemic amphotericin B, control of systemic disorders and comorbidities, and diabetes control. Caution before deciding which patient needs to go TRAMB, go for TRAMB. TRAMB is not for every case, even where the cavernous sinus is involved. Repeat imaging should be done at 4 weeks to be able to understand what was the response of the therapy that was given.